Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm privileged today to have Dr. Alan Zajarias. He is from Washington University School of Medicine. Alan, thanks for being with us.
Oh, thank you, Chadi. I appreciate the invitation.
Yeah, so we talked about TAVR today in AS, TAVR, and bicuspid, but you presented a technique and also indication for patients with TAVR and AI. So tell us about the case and what is the data now?
Sure. Well, to begin with, there currently is no FDA-approved device for the treatment of aortic insufficiency. There is a clinical trial that is about to finish enrollment for the Jena valve that is specifically designed for aortic insufficiency. The case that I presented was a case of a patient who had a significant aortic insufficiency after a valve-sparing root replacement that was treated with TAVR because the patient was of inoperable risk.
Inoperable risk, yeah.
Right.
So the graft was done many years ago?
The graft was done 6 years ago, and he presented shortly, a couple of months ago, with severe aortic insufficiency with leaflet prolapse.
Awesome. Yeah.
And we were able to place a SAPIEN 3 valve in the appropriate position, and it landed appropriately, mostly because he did have a tube graft that was able to actually hold the valve into place.
Right.
He also would not have been a candidate for the clinical trial, mostly because his aortic annulus was too large. Over the next couple of months, we're hoping that the Jena valve will come up with a larger prosthetic, and as a result, they would also be able to be evaluated in these type of patients.
So if the annulus is big, how did you manage to deploy SAPIEN?
So we oversized it and we added extra volume on our 29 millimeter prosthetic in order to assure that there would be appropriate opposition between the stent technology and the aortic root.
Yeah. So in this case, I know maybe it's a more surgical question. They re-implanted the patient coronaries, so the height wasn't a concern?
So he had multiple surgeries, and yes, his coronaries were re-implanted.
So that wasn't a concern?
It wasn't necessarily a concern. No, the reason why this case was even more complicated is because he has Loeys-Dietz syndrome, which puts him at risk for multiple aortopathies. So he had a AAA, he had a dissection, he had a previous endograft, and he had the valve-sparing root surgery. So he was incredibly ill and quite complicated.
So, in terms of planning for AI, and especially this case, did you use like 3D printing or just a regular CTA?
So this case was mostly done in a semi-urgent fashion, so we just did a CTA. We don't routinely send CTs to be 3D printed unless there's something very specific that we're looking for. But no, normally the measurements that we obtain with the CT scanner are good enough for us to be able to decide.
In terms of management post-implantation, antiplatelet, worry about AI or something like that?
So we practice with the same antiplatelet regimen that we would otherwise do for aortic stenosis. In his case, he was in cardiogenic shock, so we were able to wean him off of his inotropes and pressors, and he was able to be discharged from the hospital to have a repeat procedure for his AAA, 1 or 2 months later.
So, as you said, the clinical trial finishing up, and result hopefully will be presented soon about options for AI.
Correct. So we would need a 1-year follow-up for those patients, and then hopefully we'll have good results and good indications new indications for these technologies.
Well, thank you so much, Alan, for presenting to us about AI. Please watch these videos and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thanks so much.
Thank you.